I wanted to use this time to review a concept about prolotherapy applications when it comes to knee pain, using two clinical examples we see in the office not too infrequently. Most commonly, I'm consulted about knee pain that may be related to advancing osteoarthritis that has been approached with PT efforts. It may be someone who has maybe an old injury, or maybe they're just getting to the point where some of the old sporting activities or injuries in the past may be catching up with them. X-rays may show defined areas in the knee joint that may reflect early to moderate or even advanced osteoarthritis. The good news is not all of these conditions require surgery. Many of these have been shown to be very well deserving of at least consideration of dextrose-based prolotherapy, and sometimes PRP or platelet-rich plasma. The decision of which solution over the other would be something that we'll talk about in other videos, but basically there are multiple studies showing excellent long-term benefits from using dextrose-based prolotherapy, even with advanced to very severe osteoarthritis. Didn't matter about the patient's age, which is good news. When I've seen x-rays of some patients with very severe pain, sometimes the x-rays don't really match up with the patient's degree of pain, and vice versa. We've seen patients with fairly advanced, quite severe osteoarthritis, but not much in the way of pain. So really it's based on radiographs, but more importantly, the patient's history and a proper physical orthopedic exam to see what the biomechanics tend to show. Knee pain, when we use prolotherapy, might be a bit different if you've been exposed or received a corticosteroid injection or hyaluronic acid injection solutions, several brand names out there to help the surface of the joints. The difference in prolotherapy is regeneration of the tissue, namely the cartilaginous surface of the bones on the inside of the joint. But we also pay heed to the structure around the knee joint, not just inside the knee joint. The common teaching in prolotherapy is not only do we need to treat the area of concern, which is the knee joint, but also looking at all of the ligaments that are around the knee joint that do stabilization of the meniscus and of the knee joint itself. Examples would be coronary ligaments, medial collateral ligaments, and lateral collateral ligaments come to mind. So when a comprehensive prolotherapy approach to a knee joint is performed, we treat all of these structures, not just an inside the knee joint injection. And the thought is that many arthritic knees are presenting because of a loss of stability of those ligament structures that give the knee joint stability. Here we see a diagram of the architecture of the right knee joint as if you were looking at it from the front. And the diagram is emphasizing the multiple ligamentous structures surrounding the knee joint itself, as well as showing areas that would be the meniscus and joint space. And of course, this is always done in my office. I'm almost insisting that patients are working with an advanced physical therapy team in order to make sure that the rest of their physical structure is being attended to, because knee joint a lot of times might be the result of an unstable ankle. It might be related to hip or low back instability, or the difference when we approach an osteoarthritic knee, or possibly a knee that's had an injury like a meniscus injury, which we'll expand on, is not only will we treat the joint space itself or the intra-articular space, where the solution is going to go right into the joint itself. We're also going to be addressing the structures surrounding the knee joint. The difference in approaching an osteoarthritic knee, or possibly a knee joint that's been injured and found to have on clinical examination or maybe MRI imaging an injury to the meniscus, often the medial meniscus, is that with prolotherapy or PRP, not only are we treating inside the joint, so inside the joint capsule to get solution into the intra-articular space, but we'll also be very much wanting to treat the surrounding ligaments that hold or support the knee joint. In prolotherapy, the feeling is that osteoarthritis partly is the result of an unstable joint because of damage or injury to the ligaments that are holding structures in alignment. And if those have been injured, we will see compression affecting the joint rather than the surrounding structures. So it's very important when we do comprehensive work that we treat all of those structures, and that's what's known as a comprehensive knee treatment if we're using prolotherapy. Research papers stemming back to 2018 have found convincing evidence that medial meniscus tears that have been not completely responsive to physical therapy would be great candidates for prolotherapy. Thankfully, research has shown that very, very good results are the end result of high quality physical therapy approaches and are not necessary to go to surgery. The trend has shifted a bit compared to years ago, where any small meniscus tear or injury would go right to surgery with arthroscopic surgery. Not necessarily always the case is that needed in every patient. Papers have shown that long-term physical therapy is equally as effective as an invasive arthroscopic procedure. So it's helpful to know that along with physical therapy, prolotherapy can be extremely helpful of a tool to help that meniscus tear heal and mend. And that's what's been shown with use of dextrose as well as PRP or platelet-rich plasma.